It might work. Okay.
Oh, Hassan, can you find a place with a stronger connection to the network? Because I think that's your only problem.
Strong connection that I have. I mean, I stopped it up actually this morning to make sure, although it was okay. But I'll.
Or if you move next to the router, probably it's enough.
Oscar, I think that he's waiting. Je n'arrive pas à me connecter.
Hi, Hashad. Hi, Hashad. We can't see you now. I think it's necessary. You should turn on your camera. Hashad. Hi. Hashad. Can you hear us?
Marcelo.
Oui.
He admits who's bringing the people into the meeting. Is it you or Daniel?
Daniel.
Parce que Juan and Oscar attend.
I think Gina also. So
Gina
there are
aussi,
3 or 4
oui.
people there.
Yeah. Ah, Oscar, il est là. Ok. Oui. Bonjour, Oscar.
Gina.
Et Juan.
Hi, Gina.
Okay. Bon.
Oh, man. Daniel.
Okay. Tout le monde est là.
Everybody is entering in our meeting now.
Right. Okay.
Hi, Oscar. Hi, Juan.
Bonjour tout le monde.
Bonjour.
Bonjour.
Hello, everyone.
Tu es très élégant, Hugo. Hein? Oui, tu vas te marier, je pense.
Aujourd'hui.
Est-ce que tu as un short en dessous, Hugo?
Non. Alors, je peux montrer.
C'est un pantalon, bon, c'est bon.
Bon.
Ah, Monsieur Bismuth, il est là déjà. Monsieur Bismuth?
Les microphones, Monsieur Bismuth, les microphones.
Allez, la rigolade, c'est fini. On commence maintenant. On va travailler. Ouais. C'est l'heure. Ouais. Alors, on avait dit, je vois qu'il y a beaucoup de monde, ça c'est magnifique. Alors, on avait dit qu'on allait commencer par les cas passés pour actualiser. I must speak in English, sorry. So, we said that we will start this session by the previous case. And the previous case was by Hugo. Hugo?
Yes.
So what happened to your patient?
Well, as you recall, our patient was a patient that was retransplanted and had an occlusion caused by an internal hernia through an arterial conduit. So we had to do a resection and a retransplantation. And the patient is now fine at home. She went home at 2 weeks post-operative of this retransplantation, and she's doing very well.
I don't remember why you did the retransplantation. The discussion was about the indication of the retransplantation. No?
Yes, because at the time, the surgeon thought that when there was an occlusion, the conduit occluded as well. And so the liver had a macroscopic appearance of an advanced necrosis of the liver. And that was the reason why we decided to resect at the time, to ask for an urgent request for a liver, and then to retransplant.
And you removed the liver before having the graft?
No, at the time we just we didn't remove the liver. We waited for a new liver, and it arrived, I think, the day after.
Comment on this
Yes.
case?
Yes, Hugo.
Yes.
It was. What about the? If I remember well, there was a subocclusion, right?
Yes.
There was this big difficult decision at the time because you had a big occlusion of the small bowel, if I remember well, and you had to do a laparotomy before doing a retransplant. That's what I remember from your case, right?
Yes, exactly. So in the case we had a bowel, small bowel ischemia caused by this internal hernia through the conduits, and we had to resect. But at the time we saw that not only the conduit was completely occluded, but also the liver was necrotic.
Yeah. Did you find out on the specimen? This is what I wanted to know. What was the reason? Was it only the reason of a simple mechanical ischemia, an underlying reason? This is if you have any answer about the pathology.
Yes, it was pure mechanical ischemia. There was no problem with the liver. Besides that.
Mm-hmm.
Okay. So the patient is well.
The patient is at home and very well.
Good. When we are lucky to have a new liver, okay, sometimes it's the best solution.
Yes.
Okay, now another case was Oscar.
Yes, it was mine. It was a lady of 61 years old that she began with abdominal pain and mild acute pancreatitis was repeated twice within 1 month. CA 19-9 levels were high, around 200, excuse me, and a biliary stricture, an organic biliary stricture was found in the intrahepatic bile duct. An ERCP was performed and a stent was put in the place of the stenosis. And she has an history of some autoimmune disease in her family. Her mother died by an autoimmune hepatitis, and her aunt has primary biliary cirrhosis. However, autoimmune markers, IgG4 and NAF and asthma were negative, were normal, but we thought that she had an autoimmune pancreatitis. In an endo-ultrasonography, no mass in the pancreatic head, but no biopsy was performed at that time. So we discussed if we have to perform a new biopsy in the head of the pancreas or put on steroids. Began steroids about 20 days before, but she had an acute cholecystitis and she had to be operated, but this acute cholecystitis with no lithiasis. It was an alithiatic acute cholecystitis, and the surgeon who performed the surgery, laparoscopic cholecystectomy, thought that the stent was obstructing the cystic duct, and it was the cause of the acute cholecystitis. She's doing well. She was discharged at postoperative day 2, and now she's on steroids, and all the figures were down, now normalizing lipase, amylase, alkaline phosphatase, transaminase, and bilirubin. The only thing that CI19-9 is still around 190, and we are waiting to perform a new cholangio MRI to see if the steroid treatment was working on the stricture in the common bile duct. Some discussion was arise by Jean Robert del Peró and Eduardo Barroso about the usefulness or not to perform an pancreatovenectomy, but we decided to wait a little bit and have new images after 1 month of steroids treatment.
Can I make a comment, Professor Bismuth?
Yes, yes, please.
Oscar, sorry, I wasn't at the last thing. I didn't see the images, but I understand probably the stent is still in situ now. And
yes,
I think you're going to have maybe difficulty seeing the images really well if you do an MRCP with the stent in situ. I imagine it must be a plastic stent and not a metal stent. And you also have a concern about cancer with the elevated CA19-9. Why don't you propose an ERCP and brush it again and have a very good look at the stricture? Then you can see whether the steroids have really made a difference or not.
Well, John, this is another of our ideas to withdraw the stent and at that moment to brush the common bile duct. But I think that it is still on our mind to do that, but we waited to do firstly an non-invasive image to see what happens.
Yeah, I mean, you can also do the MRCP first. I agree with you. Yeah, yeah.
Eduardo and Jean Robert had a big discussion about the indication of duodenal-pancreatectomy. Now, what after 1 month of duration and after what said Oscar, what do you think, Eduardo?
Turn on your microphone, please.
Microphone.
Yes, please. It's all right now?
Yes, yes.
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 Yeah. I think the patient has an autoimmune pancreatitis and a cancer of the pancreas and the cancer of the bile duct. And she needs a duodenal pancreatectomy. And the age of the patient, if I remember, is 60 something, no?
61.
61. It's too young, you know. Okay. I know that my friend Del Peró thinks that's a crime to do this operation. It depends of the morbidity and the mortality in your hands of that kind of operation. But I think there's a serious doubt that patient could benefit of a resection. And if you have a mortality and a morbidity almost similar to this ERCPs and this kind of manipulations of the, but those done by the gastroenterologist, I think that patient, this CI99, and that patient has also a malignant disease of the bile duct of the pancreas. It's my opinion. And if you don't operate, I can have reason, of course. Only in the autopsy you can prove that I am right.
Jean Robert said it was a crime to do duodenal-pancreatectomy. Now, the question, Jean-Robert, now, do you think we may exclude the cancer in this patient? Jean-Robert.
Turn on your microphone.
Jean-Robert, microphone.
That's okay?
Yes, yes.
Few comments. First, okay, we are cautious that the patient had perhaps malignancy with the pancreatitis. However, the lipids go normal in few time after the beginning of the corticosteroid. This is the first point. Second point, CA99 maybe 1 month or perhaps 2 months to normalize. Never in normalize directly. It takes a relative long time. And John Isaac is completely right. If you want to have a good MRI, you have to remove the stent. So, in my opinion, despite the anxious situation of a malignancy of the biliary tract, I wait, I do another imaging, and I think that's perhaps the patient has only a pancreatitis. And I think that if you do the pancreatectomy, whatever your experience, the pancreas is soft, had pancreatitis, multiple episodes of pancreatitis, so the morbidity is not quite the same that a standard pancreaticoduodenectomy. It's quite a little bit more high. And another problem is the diabetes, and if you do the pancreatectomy, the patient had a 25% chance to be diabetic. So probably waiting 1 month or 1 month and a half more, it's not a fault. This is my opinion. I hope I am not wrong, but
no, I respect a lot your opinion, but the patients are not treated by images. The patients are treated by other reasons. The images don't treat the patient. I don't know why you need another image. Why you need another image from the biliary? Why? This
because
is not.
Eduardo, Eduardo, because with steroid, perhaps the imaging is normal.
Yes.
It's possible.
Yes.
It's possible with corticotherapy to have a normal MRI after the treatment. I think it's
yes.
Sorry, may I put the image again? Do you want
yes,
to? I have the images here. If you want, I can put it again.
The image of the Wirsung is important, not the image of the biliary duct is not so important. Is the Wirsung image is important.
But
please, Oscar, show
the main pancreatic duct was normal, Eduardo. It was not dilated.
Yes, I know that. This is against
and no mass in the endo ultrasonography was found. So we have both. And a third decision was a third cause of decision was that sign of the duct penetrating sound, a sign in which both the common bile duct and the main pancreatic duct were seen through the area of focal pancreatitis, and in cancer we don't see that. But you perhaps you're right, and the case is still open, and we were a little bit delayed in the second image because the acute cholecystitis that she was operated on last week, so it was some delay that caused some delay in the new images. But if you want, I have the images here. If you want to see again.
No, Where what's the image? I don't want the image. It's only.
Okay, so what the question is: are you sure there is not cancer? This is the question today, and somebody answer about that with special examination. The brushing was proposed, or we wait a little more, you remove the stent, What you propose, Oscar?
I want to ask Jean-Robert, how many time do you wait to remove the stent now? Do you remove the stent?
If the patient is okay, you can remove whenever you want.
Okay.
And
Okay.
probably after removing the stent, you can do the MRI few days after, and it's very interesting because we see.
Okay.
Okay.
Eduardo, I'm sorry because perhaps you are right. Perhaps the patient had a cancer.
Yeah,
okay.
but I am not right. I know. This is my life all the time like that. Okay, I am trying to be provocative. I am trying to be provocative and with the personal experience to know that sometimes we have this autoimmune pancreatitis and also the cancer.
I agree completely. I agree completely with you. However, we have a follow-up of 45 days.
Yes, of course. Wait a little bit more, yes.
45 days. Perhaps if there is a cancer, something had already happened, no? Perhaps. Correct.
I just have a comment about.
I think that waiting 1 month more is not a problem, even if the patient had a cancer.
Yes,
this is my opinion.
Yes, I agree with that.
Can I make a comment?
Oh,
yes, Laurence.
Hello.
With pleasure.
Everybody.
Hello, Laurence. Hello.
Hello.
So this situation is not so rare to have the difficult diagnosis between cancer, which is here more than a cholangiocarcinoma than a pancreatic carcinoma.
Yes.
And, this is quite a frequent issue when you are doing a lot of pancreatic surgery. And I think, excuse me, Eduardo, but pancreatidoneectomy is not a little operation, even in good hands. So I think that in that case, you have to remove immediately the stent and wait for 1 month of steroids. And if it works, it will work. And you'll see that the hepatic profile will be okay. And I don't think that it is a loss of chance doing that, because if it's a cancer, the stenosis will appear again, and you will be authorized to operate. So remove the stent, wait during 1 month or 2 months, and see what happens. If the stenosis is there, operate. If not, I think it's a autoimmune pancreatitis or cholangitis. I heard that the medical history of the family had autoimmune. So this is I think this is a point quite important to consider. I don't think that it's a loss of chance to wait.
Thank you, Laurence.
Mr. Bismuth?
Laurence, so the conclusion is that today, Oscar, you may remove the stent. You wait. How many days after the operation we are? How many? No, after the stent. How many days after the stent? More than
now
1 month, I think.
we have about the stent was put, I think, on the 7th June. 1 month and a half. 45 days of stenting.
Just one more comment, because this is very important. I experienced that you must be careful, because sometimes when you are putting steroids on malignant stenosis, it can improve temporarily. So be careful. It can improve. So you said, okay, we win, but wait a little more and the stenosis will appear again. So it's not, I think it's important to wait long enough to conclude in a benign stenosis.
Okay. Okay. Thank you.
Okay.
Thank you very much.
Okay. We go on. We go on. So one point. Thank you, Oscar. Thank you. Now we have approximately 10 people outside. They are not on the screen. We are seeing the name Valerio, Carlos Eduardo, Prashant Bangui. They are outside waiting. So Marcelo, what to do? It is possible to put them, you remove some of us, you put others, we change like this, okay? In order to give them the possibility to be on the screen and to participate more actively. We are 16 on the screen, which is the maximum, but 10 are outside. Manuel Jacquelist is a presenter. You have to present something. May you put him on the screen?
Yes, Monsieur Bismuth, each time that the people speak, it's open the screen on the yes.
Okay. We did not finish now for the previous case. There was a case presented by Fulvio Callis. Fulvio is here? No. And
I think Fulvio is not here.
He's not there.
And now Christian Tozo. Christian Tozo is not here. He sent a mail yesterday to me saying that unfortunately will be now in a plane, so not possible to speak. But he said that he operated on his patient. He was an hemangio on the teleoma. He resected, but there was a cardiac, on the cardia, there was a lymph node, a positive lymph node on the cardia. And he say, I did a palliative operation, but as the form is not so bad, this is justification to do the resection. And I think he will do a chemotherapy, I think. Okay, we may speak about this case later, for he's not here. Now we go to the new case. So Rashad, I know there is Rashad, Manuel Jacquelist, and other case. Dimitri is here. Dimitri Alden is here. You may start, Dimitri.
Okay, so I need to share the screen. Let's see, just 1 second. Can you see my screen?
Yes.
Yes.
Okay. So, good morning, everybody, and thank you. So this is a case of a 36-year-old young African-American female who presents to the emergency room multiple times to different hospitals with severe right upper quadrant abdominal pain. Her symptoms developed about a year ago after a laparoscopic cholecystectomy that was done in another institution, not in mine. Big university hospital, reputable place. She says that there were some difficulties and pain immediately after the operation, but then she recovered. The operative report does not demonstrate any kind of unusual scenarios or anything like that. Everything seems to be just a standard cholecystectomy done laparoscopically. So on examination and discussion with her pain rapidly intensifies after approximately about 30 to 45 minutes after food intake, which rapidly is followed by nausea and vomiting. And she reports 130 pounds or 59 kilogram weight loss in 1 year period. She has absolutely no past significant medical history. She's a mother of 4 children. She had 2 vaginal deliveries and 2 C-sections, no other prior surgery. And she has no other medical problems. So this is her blood work, which is essentially all normal. There's really nothing abnormal in her blood test. I did a CT scan, and this is what we see. You could see the bile duct and massive cavernous transformation of the portal vein with open splenic and open superior mesenteric vein and complete occlusion of the portal right from the portosplenic junction all the way up. So I think that's, okay, I need to advance the slides the same scan. So this is a coronal view. Which is a little more representative. I have still images later on, so you can take a look more. So these are the still images of the CAT scan. As you could see, it's pretty impressive portal vein thrombosis with massive cavernous transformation. You see the image of the common bile duct here. So I proceeded with the further workup and did an MRI, an MRCP. And it's interesting, if you see here, there is a remnant of the gallbladder, or it's a very, very dilated portion of the cystic duct. Clearly see here. So this is, I decided to do a HIDA scan to really understand whether it's related to this pain related to biliary dyskinesia, and the scan had to be interrupted after CCK injection to the point that she needed morphine injection. She developed so much pain. So this is the study. I want to point out that there's this area here which is a little bit questionable whether it fills that space of the enlarged cystic duct or the gallbladder remnant. But I was present during the test, and the woman really was screaming in pain literally seconds after the CCK was injected. And so we did an angiogram. And it doesn't look like there's any kind of arterial injury on the angiogram. The superior mesenteric vein also appears to be normal. I mean, superior mesenteric artery appears to be normal, and the hepatic arteries appear to be non-injured. There's some clips from the gallbladder operation, and you don't see anything else. These are the venous images of the angiogram, which is not surprisingly show you that you have a patent superior mesenteric vein, kind of thinned out and small splenic here, but then the rest is completely obliterated. And I will stop here, and I would like to open this case for discussion to see what should we do with this patient.
Tell us, Dimitri, at the time of laparoscopic cholecystectomy, the surgeon discovered nothing abnormal? Normally, the kind of cavernomatous transformation portal vein, there is large dilated vein in the portal pedicle.
I have the operative report.
He said nothing?
I have the operative report from laparoscopic cholecystectomy, which was done approximately 16 months ago. There is not one line mentioning any abnormality. And the operation was done in a pretty reputable place. I'm not going to mention, but so it's not.
And what was the indication? What was the indication of cholecystectomy?
The indications, the indications were gallstones. She had 4 pregnancies. She had gallstones, and she developed acute cholecystitis. One thing I forgot to mention in here that we did a very extensive hypercoagulability workup in her, and it's completely normal. There is really not one abnormality. I asked the consultation for the from the director of hematology of our institution, and they run numerous tests, and they all came back normal. So it's a little puzzle to me.
So Dimitri? Good morning, Dimitri. Nice
Good morning.
case.
Good morning. Good morning.
Just a question. Do you have the pathology from this particular case?
Oh, yes.
So I guess the question is, did this proceed? Did this cavernous transformation precede the laparoscopic cholecystectomy, or was it caused by? Especially if the previous surgeon in the operative report did not indicate any abnormality. And I would also just make a comment that I think what you're looking at is a remnant gallbladder, because you can clearly see the cystic duct connecting into the common bile duct. And perhaps there was some sort of abnormality, which is the reason why there is a remnant gallbladder.
Well, as far
so
as
just the pathology?
Well, the pathology showed chronic or acute cholecystitis and gallbladder. Interestingly enough, there's no mention of the cystic duct on the pathology, which is interesting. But the question here is, she clearly has symptoms of, I guess, so to speak, biliary dyskinesia without the gallbladder, because the symptomatology and hepatobiliary scan clearly demonstrate that the pain is related to stimulation of the biliary system. The question is here, what's the cause and what's the consequence here? Of the pain I'm talking about. Is the pain related to the remnant of the gallbladder and still presents as a biliary dyskinesia symptom? Or is the pain related to the portal hypertension and portal cavernous transformation? And Monsieur Bismuth will tell us, I clearly remember all these teachings about the portal cavernous transformation with the fact that the veins actually end up being inside the lumen of the bile duct and causing intermittent obstruction or near complete obstruction. And the question here is, what is the solution to this case? Also, is the solution to remove the remnant of the gallbladder, or is the solution to treat the portal hypertension, or both? And in what sequence? And that's what I would like to hear from the compagnon, what you would do. How would you handle this case?
Dimitri, I would like to say 2 things. One, really, I think in my experience, I am not sure to have seen one case of remnant of a cystic duct with a so important symptomatology. You said that she is losing weight, she has severe pain, vomiting. I don't think this could be in relation with a remnant cystic duct. I don't quite sure. I don't know. I would like to have your advice about this. May a remnant cystic duct may give this kind of symptom? I do.
No.
Yes.
No.
Yes. I disagree.
No.
I respectfully disagree.
Well, that's why I'm presenting this, because it's going to be good. Okay, let's talk about
this. Personally, I have seen this at least 3 times of a remnant gallbladder, perhaps not only a year or 16 months after surgery, but a remnant gallbladder with the ability to form stones and cause recurrent symptoms. And I have operated on and improved the symptoms or ameliorated the symptoms of these patients. So I respectfully disagree with the group that a remnant gallbladder cannot cause recurrent symptoms. Of course, this has to be in the presence of gallstones.
That's
Yes, absolutely. The remnant of the gallbladder may or may not cause the symptoms, but the question here is what to do here, because as you can see on the images, we can go back and or can show it again. That remnant of the gallbladder is surrounded by absolutely an incredible size varices and portal cavernous transformation. So I think to try to get there and dissect this, it's not going to be an easy task. Also, I also did an endoscopy. I didn't put it here, but she doesn't have any esophageal varices. So, which tells me that this is a fairly recent development of the cavernous transformation. But it's very impressive, and I'm not sure how I would approach this problem.
Can I say something?
Sure.
Dimitri, there are two separate problems. I agree with Ellen that yes, sometimes you can have symptoms related to a remnant gallbladder, but the way you describe this patient, the fact that she lost weight, so
right.
What we're facing here is symptoms related to acute portal vein thrombosis, and we know that portal vein thrombosis, portal cavernoma, when it's chronic, you have less symptoms, and then you can see the consequences. But the symptoms here, it appears to me, given the fact that your blood tests were entirely normal, so it's symptoms related to acute portal vein thrombosis. So today, I will focus on that, because regardless of the remnant gallbladder, you cannot treat it at that time. So what I need to know is to see what's the gradient, what's the state of the liver. Is it an arterialized liver? I will do liver biopsy, and then I will go to the second step to treat this acute portal vein thrombosis. This is my feeling today.
Now, one word. First, you know, portal thrombosis may be asymptomatic, and sometimes is discovered very late in the life. Totally asymptomatic. That means we must be careful. It's really this cavernomatous transformation of the portal vein is recent. I don't know. And this is my question. There is inflammatory sign today, Dimitri, in the patient. Sign of inflammation.
No, I don't think so. She has pain. This pain has been going on for approximately 1 year, and she's been going from doctor to doctor. Finally came to me. I did all this workup. So
look, my trouble is that I have the feeling that the symptom, which is very serious, that of the patient, seems to me not to be in relation nor with the remnant cystic duct, nor with the portal thrombosis. You know, the sign of portal thrombosis, you know what is the sign of portal thrombosis? Is bleeding, esophageal bleeding, when succeeds. Right. It is not sure she has esophageal varices. You know, for when there is a huge portal transformation, all the portal flow return to the liver without esophageal varices. Now we have to check that in case she has or she don't have. But anyway, she has no bleeding. The second point is the trouble of portal is the. But you said there is no disturbance of the coagulation. You said that?
No. Yes, I did. I said that. There's no problem. Her hypercoagulability workup was negative, and her blood tests are essentially normal.
At that time, there is intestinal sign like pain after eating.
No, but the pain is localized in one spot in the right upper quadrant. Really, she pinpoints this pain in one area. This pain, we brought her down for a HIDA scan, and she was completely normal and asymptomatic. As soon as we injected the CCK, within minutes, this patient was screaming in pain on the wall. So we did an endoscopy, which was essentially normal. She hasn't had any problems prior to that cholecystectomy operation before. I spoke to her, I spoke to her husband. They're very reasonable people. They're both working people. They're not looking for pain. She's not looking for pain medication. She's not asking for narcotics. I'm absolutely convinced that this pain is related somehow to this problem because it appeared in just a few months after cholecystectomy.
Can I make a comment on this? I'm pretty certain that this portal vein thrombosis and the cavernous transformation is a chronic thing. And it's unrelated to her pain now, as Professor Bismuth said. I think the surgeon stayed well away from the common bile duct. Perhaps he saw these big veins and he did a subtotal cholecystectomy.
Correct.
And I'm pretty sure that this is biliary dyskinesia, the presentation of the pain being perhaps unmasked by the cholecystectomy, points to a biliary dyskinesia. Very often sphincter of Oddi dysfunction behaves this way, although I haven't seen patients jumping off the table with sphincter of Oddi dysfunction, but it can. I can only suggest one thing. I think you cannot test for sphincter of Oddi now because you got a partial cholecystectomy. That's going to interfere in your analysis. But I would suggest one approach, and that might help making the diagnosis of sphincter of Oddi, and that would be as a Botox injection to the sphincter. If you do a Botox and we're correct that this is sphincter of Oddi, hyperpressure with dyskinesia, you will get pretty good temporary relief. And then at least you'll have a diagnosis as to the cause of the pain.
That's a good suggestion. It's interesting. Absolutely.
Dimitri, may I ask another question? Going back to the history, you make a very good point about how her pain increased with the CCK injection. What is the pattern of her pain? Is it postprandial? Does it seem like it's biliary? Because if it is, then I think by history, you have your answer. The second point I wanted to make is that if she received morphine, that's not going to do anything except for just increase her pain, right? With the contraction of the sphincter of Oddi.
Right.
And I think that John's point, and well taken, to try to open up the sphincter of Oddi and see if she has some temporary relief may also give you your answer. Right.
My question is everyone comfortable manipulating around the papilla endoscopically in the presence of such massive size varices? Are we running a risk of bleeding?
Can I come in?
Yeah, if you're planning just to do a Botox injection, I wouldn't worry. And you alluded to what Professor Bismuth said before, the portal biliopathy that can occur. Looking at the MRCP, it's plumb normal. So I don't think she has portal biliopathy. I think she has a chronic portal vein thrombosis, and she doesn't even have much portal hypertension, really. There are no varices. So I would say that something like an injection, even a small sphincterotomy, probably safe. But I'd start with the injection for Botox, even more safe than a sphincterotomy.
Can I make a comment?
Wants to say something?
Yeah. See, we have a large experience of this is portal biliopathy, no doubt. If you see the MRCP, if you can put it up again, the change, the irregularity, subtle irregularity which you see in the lower bile duct, they are classical of portal cavernoma compressing the bile duct. There's no doubt about it. The liver appears to be normal. Gallbladder remnant is quite large. Okay.
Let me put this back up again.
Yeah. And meanwhile, I will also like to know what were the liver function tests. Any abnormality of the liver function tests? Alkaline phosphate
the liver function tests were normal.
Okay. So it's in portal biliopathy, you may have the patients who don't have varices because the whole thing is diverted into the cavernoma and compressing the biliary tree in that intraductal and periductal varices. And they may not develop the esophageal or gastric varices. We have seen this. They may not present with the bleed, and they will present for the first time with the pain. Now here, the pain which was there before cholecystectomy has never disappeared. Okay, it's never recurred. It's never disappeared. We should say that. And the gallbladder remnant is significant, which shows that the surgeon, realizing the danger of doing the complete cholecystectomy, he didn't go toward the hilum or toward the cystida, which was a wise thing to do.
What's surprising to me that they didn't mention anything in the operative report.
Yeah, that's possible. That's possible. There's a possibility that they didn't notice it or they didn't mention it. But you see that cystic ductal stump is quite long, and the gallbladder is quite large if you see the MRCP. And yeah, now you see, stop here. If you can re-rotate it. No, go back.
Oh, you mean
no,
go to the
MRCP?
MRCP?
What we were showing the same MRCP,
yeah.
And you can see the irregularity of the bile duct, which is classical of portal biliopathy. So we'll have to accept that the pain is originating from the gallbladder polyps, which had never disappeared. It has remained there. The cholecystectomy cannot be completed in presence of large varices there. So the plan of treatment in these cases will be first do a proximal linear shunt, decompress the peridocal varices and pericholecystic varices, and then reassess this patient whether the pain persists. Because sometimes the decompression itself, the partial obstruction disappears, and the symptoms may disappear. If the symptom persists after that, then because we have achieved the significant portal decompression, one can do the cholecystectomy in these cases, not at this stage. Second, the sphincterotomy is a dangerous game in these. We have seen the patient developing severe hemorrhage during sphincterotomy because of those varices in the region of the pancreas. So the plan of management for this patient should be a proximal linear shunt. Mr. Bismuth will agree with me on this.
Okay. Let me ask you a question regarding the shunt, because I went back and measured for the size of the splenic vein on CT scan and on the angiogram, and it's only 8 millimeters. As you could see on the angiogram, the splenic vein is a little rattled. I would say it's not in really good shape. So I'm not convinced that a proximal splenorenal shunt, which also requires a splenectomy, is probably the best choice of the shunt.
Okay.
Why not do a mesocaval shunt, which is technically actually very easy to do, and then you can have a choice of either jugular vein or a PTFE graft, and have the caliber that you want. Because with 8 millimeter splenic vein, I'm not so sure I can achieve a good decompression.
Okay. 8 millimeter is not a contraindication. As a matter of fact, if you read the article by Professor Bismuth in children, he went down to the 4 and 5 millimeter, and he described the technique of how to keep these stent patents by using the technique of switching. So 8 millimeter is good size. Second thing, you can, if you don't want to do a splenectomy, you can do a side-to-side splenorenal shunt. And I've described this, and we have used it, adrenal vein, dilated adrenal vein, and used it as a conduit to attach to the splenic vein. And that works as well. So you don't have to go and dissect into the, for the superior mesenteric vein. So, and that's the alternative, which is a simpler option. So you can do side-to-side. 8 millimeter vein is not a contraindication. You can use the adrenal vein as a conduit there if you find the issue of doing the side-to-side. Mr. Bismuth can comment whether he can do the proximal shunt in these cases or not.
Yes. Let me tell you, Sundra, I think what is the indication of the portal decompression? There is no sign of portal hypertension. There is no sign of portal hypertension. The trouble that have the patient is not at all in relation with portal hypertension. So I don't understand why to do decompression. I don't understand. No, really, you spoke, of course, we think about portal biliopathy, but portal biliopathy is obstruction of the bile duct. But she has obstruction of the bile duct on biology, Dimitri.
Dimitri, may I say something also?
Yes.
Yes.
Okay. Do you want
Eduardo.
to that patient? Yes, please. This is nothing to have this bilial portal biliopathy. Nothing. This is not portal biliopathy. Mature is a big experience and a lot of papers about that. This is nothing to do. If you want to treat that patient, please take out the gallbladder. That's all. Take out the gallbladder. How many gallbladder I have
The
taken out
question is
with
how.
portal hypertension? With portal hypertension, this is nothing to do. Take out the gallbladder. Gallbladder is there. So it's a very not so difficult operation. It's very different.
Eduardo, I agree with you that the gallbladder has to come out. And to make the gallbladder cholecystectomy safer, you have to do the shunt decompression.
It's completely different. To treat portal biliopathy, I agree that you need to decompress the portal hypertension before you do biliary anastomosis, the biliary anastomosis.
Right.
But this is nothing to do. This is just to take out a gallbladder in a patient with portal hypertension. I have done dozens of that operations. Everybody has done. It's a difficult gallbladder operation. Please take out the gallbladder, treat the patient. Stop the examinations. The patient has the gallbladder in situ. I don't know if it's a duplication. The gallbladder is there. I don't know if it is a remnant or if it's a new one. Please operate the patient and take the gallbladder.
Okay, but if we take out her gallbladder remnant and don't decompress the portal vein, and she still has the pain, then
no.
I have a legal problem, most likely. If I decompress her portal system and take the gallbladder out, you all will say, well, she didn't need a mesocaval shunt or because if you only took the gallbladder out, you
don't need to do the compression of the portal hypertension. Take the gallbladder. It's a very easy operation for extension. No problem.
The issue is the first surgeon attempted and couldn't take out. So Dimitri, you have best of luck. You try to remove this gallbladder.
But honestly, I'm not very excited going into that area, trying to get this thing out. Maybe Eduardo should fly over here. We'll do it together.
Yeah.
Look, I am sorry to say one word. Also, I am not sure that the remnant gallbladder has a responsibility in this trouble. I keep on the trouble of the patient, and she has very severe trouble. Weight loss. You said 59 kilo weight loss?
She lost 59 kilograms in 1 year. She lost. Yes, she can't eat.
Did you see that for remnant gallbladder weight loss?
No.
It's impossible.
Impossible.
No, impossible.
No, impossible. I agree. No.
You forget to tell us that you have done a bypass operation. You forget to tell us that she has made a operation for the obesity.
Dimitri,
she doesn't eat because of the pain. She can't eat. She's afraid to eat.
So Dimitri, why not take the advice of John Isaac and see if that improves her pain? With the assumption, it seems that this is a low risk procedure.
No, I agree. It's a good idea.
And why not see if this improves her pain? That would give you justification for removing her gallbladder if you deem that's safe enough to do so.
Anybody else has a comment? Hugo.
Or even sphincterotomy following
Laurence, I would like the advice of Laurence.
Well, to my opinion, it is really impossible that this remnant gallbladder is responsible for the state of the patient, the loss of weight. I think she has a disease. The main point is to understand why she has these
symptoms
thrombosis at this age. You said you had a complete checkup for that, but the point is that you are focused on this remnant gallbladder. I agree, Ellen. It's possible to have some trouble about that, but not that. So if I forget the cholecystectomy, you present this patient with the loss of weight and this portal thrombosis. I say she has a cancer. I don't know, but I think you have to understand why she has this thrombosis, and this is for me the cause of the real symptoms. The gallbladder for me is not
secondary.
The responsible.
Laurence, I have a remark also. You know, the way they did the cholecystectomy with this large, important remnant bile duct, cystic duct, could be that the surgeon found the cavernomatous transformation and it stay apart.
Right.
That means it could be that no, the portal hypertension, the extrahepatic portal hypertension exists before. It could be exist before the cholecystectomy, and this explain the remnant cystic ducts. And now I think that the two signs that we have, that means the remnant cystic duct and the portal hypertension, is not in relation with the symptom of the patient. And there is something else that we ignore. And personally, I will be very, very, reserved to do nor cholecystectomy in this patient, nor a portal derivation in this patient. I am quite sure it will be a catastrophe, but I don't know. I have no answer. I have no answer.
That's what I wanted to say.
So what would you do? No, what would you do, Monsieur? What would be your next step?
Cholecystectomy.
No.
This is not a remnant gallbladder. This is the gallbladder is there. This is not a remnant gallbladder. This is the
gallbladder. Laurence, you brought up a point of perhaps this is a cancer.
Well,
so why not? Has the patient had an endoscopic ultrasound or something of the sort to evaluate that further, Dimitri?
Yeah, she had an endoscopic ultrasound, showed portal cavernous transformation, and that's it.
And no mass.
No.
Can I? May I say something?
Sure.
Yeah, Dimitri, I agree with Laurence, and that's what I said initially, and I agree also with Mathieu. I think that initially this patient had pain unrelated to the gallbladder. So I agree with Professor Bismuth. She had this portal carcinoma since the beginning. The symptoms were related to probably this. They've done, as you know, when you go to any other hospital, people jump on the gallbladder. So they've done a partial gallbladder because they are nuts. Okay, we know that. Instead of saying, no, let's see what's going on. I had these cases many, many times. But I agree, and I said initially, I need to go further to what's the cause of this portal vein thrombosis. This is a 36-year-old lady, African-American origin.
Dimitri.
We need to go further in the investigation, and I need to do more, even a liver biopsy probably. I need to go more.
Okay, we can do a liver biopsy. That's easy to do. But why don't we give the word to some other people who are not on the screen? I see a lot of other compagnons and guests. Does anybody want to talk? Like Marjan, what do you think?
Dimitri, did you check the lipase during the pain?
Well, her pain is essentially every time she eats. So
yes, but you know, some pain after eating is either biliary or pancreatitis.
Right.
So this is the portal thrombosis is located on the splenomesenteric confluence, so in the pancreas. So I'm wondering if those pains are not related to pancreatitis and not biliary, which explain why CCK is increasing the pain. Honestly, it could be more pancreatitis than biliary, and this would explain the portal thrombosis also. Concerning what said Professor Bismuth, I think that I'm confident in my colleague, and I think that if the previous surgeon saw this enormous adenoma, I think he would have say it. I'm a little suspicious about that, but I think that could you just try steroids?
It doesn't hurt in this settings. I think it doesn't hurt to try steroids. We can get the Botox injection, like John said, and we can try steroids. I don't have a problem with that.
Steroids for something autoimmune, something like pancreatitis. I don't think that is a biliary. I never saw biliary pain like that.
But Lawrence is saying pancreatitis pain doesn't come
in absence of any evidence of pancreatitis. How do you justify the pancreatitis as a diagnosis?
I tell you,
evidence to say that this lady had a pancreatitis at any stage.
Dimitri,
amylase and lipase are normal.
Dimitri, you know what is my advice? When a surgeon don't know, he don't need to do something. I mean, don't act when you don't know. Personally, I will think more on this patient. I will see the patient, explore more, listen the type of pain, when the pain arrives, go a little. I cannot give you the indication. I don't know, but I will think more about this patient. And today, really, if I have this patient in my office, surely I will do no surgery, for I don't know what the patient has. Well, this is my advice. Yeah, it could be I am wrong. It could be your other advice. But personally, I will do nothing on this patient. I will look at her more and more.
So what I would like to do is, we have a bunch of people here, and I would like to take just a very quick vote. Okay, we have your vote. Dr. Matura recommends a shunting procedure. Ellen?
I would follow the recommendation of John. I would do some Botox and follow her symptoms. Again, I respectfully say to the group that this is postprandial pain. And I agree with further investigation, but I suspect that it's biliary.
Okay, let's just do a quick sum, because I would like to see what everybody else would do. So Gina?
Gina, your microphone.
You're muted.
I will need to do further tests. I'm not sure what's going on here, and I don't want to miss something. I'm not 100% sure that the pain was related entirely to the gallbladder.
Okay. So we have the opinion of Monsieur Bismuth. John, we have your opinion. Hugo? You're muted.
I also agree we should investigate more. I think this is biliary. I think the hypothesis of pancreatitis causing this makes some sense. And I think we have to investigate a little bit more in that line. I wouldn't do an operation right now.
Yes, because you don't work anymore with me. I am telling you one thing. That patient had a problem in the gallbladder. He had an operation to take out the gallbladder, but they missed to take out the gallbladder. The gallbladder is there. The gallbladder is there. So I don't understand why we don't think that's the problem of, if they have a pancreatitis, is perhaps a gallstone pancreatitis is also. So I don't understand why you don't take out the gallbladder of that lady. The gallbladder is there. It's not a remnant gallbladder.
Okay, we know the opinion of Eduardo.
I think there is a reason
that there is no cystic duct. There is no cystic duct in the gallbladder that was taken out. Yeah, there is no cystic duct.
I think there's a reason Eduardo and Surendra are on the opposite sides of the screen.
I like to treat
and John
patients.
is
I
in the
don't like
middle.
images.
Okay, Laurence?
I told you, I don't think it's the gallbladder. I'm sorry, Eduardo.
Yeah.
And I think that
That's great.
further investigation and just try to understand why she has this portal thrombosis. I think it's the key of the problem.
Oscar?
And biliopathy not.
Yeah,
So
the portal thrombosis.
eventually, of course, the Botox first, then steroid, then I don't know.
Okay.
Yeah. Okay.
Oscar? Oscar?
Yes.
Okay, what's your?
Well, do you want my opinion?
Yes.
I'm so confused as you. I think that first of all, the weight loss could be either by pain. She has she's afraid to eat and she doesn't eat and weight loss, or it will be by some malabsorption by the portal hypertension. The small bowel could be congested and no good absorption. Maybe the cause of the weight loss. So for the first time, you should rule out, I think, that she has some hypertension in the small bowel causing malabsorption. And in that case, you have to treat this portal hypertension. If not, I think she has no varices, so you can wait and perhaps realize if the remnant of the gallbladder is the cause of the pain. What is very confusing is that the pain began after the cholecystectomy, and she didn't have pain before. So I don't know if some link between portal hypertension, which I think is chronic, is the cause of the pain.
It's hard to tell. Yeah,
Was her pain not before cholecystectomy also, Dimitri?
No,
the
not
indication
the same.
for gallbladder?
No.
Can I ask one question, please?
Not the same. She had acute cholecystitis, which she presented rapidly. She was absolutely fine. She developed typical symptoms of acute cholecystitis. The gallbladder was removed, and her pain was resolved.
And lithiasis? And gallstones on her pathology?
Yeah. And then several weeks later, it started and then intensified more and more and progressed, and then picked to the point that she couldn't eat and lost weight. There was a question here on comments about SMA syndrome compression.
Dimitri, I want to make one question, please. Did you consider to treat by percutaneous treatment with antifibrinolytic treatment and stent to treat the portal hypertension and portal thrombosis? And then, because probably this, in my opinion, this is a result of the surgery. It was a complication of the first surgery. So I think the treatment by percutaneous treatment with antifibrinolytic, you will solve the problem of portal hypertension. What do you think?
Well, I think percutaneous treatment of the portal hypertension, I don't think that we can recanalize the portal vein. I mean, we've talked about it, but I guess you could go transplantic and try to go through the splenic vein up and try to recanalize it. There is a reconstitution of the portal vein in the liver, which is probably why she doesn't have esophageal varices, because it's just such a massive cavernoma that it compensates. But I think to recanalize that, I think it's not going to be possible. We've talked about it and kind of decided against it. As far as the fibrinolytic therapy, I think it's useless. Honestly, I presented that in Dublin, if you remember that we had a whole series of portal vein thrombosis after bariatric surgery. And they all got treated with fibrinolytic therapy, and not a single one of them opened up. They all ended up with portal vein thrombosis. So I'm not in big favor of fibrinolytic therapy and portal vein thrombosis. I just don't think it works that well unless someone has different experience. But
Dimitri, I have an idea for Eduardo. If you think it's the remnant gallbladder responsible for the pain, so I have a proposition. Drain the gallbladder. This is a diagnostic test.
Whoa, that's
yeah. Why not?
But drain the gallbladder.
Well, why not? Because it's probably very. Eduardo, just one second.
I bet.
I think it's very hard to see on the ultrasound. I think it's going to be very hard to see, but yeah, I didn't think of that. That's a good idea.
You don't know unless you try. That's a good suggestion.
Well, you know, but if you stick a needle into one of those varices, you're going to have an
No,
endless.
it's not. It's you will not. On the CT scan, the remnant gallbladder is not surrounded by varices. So on ultrasonography, you can drain this famous gallbladder, and you'll see if she has no more pain. Okay, Eduardo will be the winner.
I like to treat patients, you know. And that patient is, for me, so obviously. Of course, it is very strange. Everything is very strange. I think you have this portal, the cavernoma, after 30 years, I don't know how many, postpartum, post-delivery. Perhaps it's post-delivery. It's an African origin of that lady. And perhaps this is an old cavernoma, no symptoms. You don't need to treat portal hypertension. She has no risk of bleeding from varices. The liver function are normal. Everything is normal. She had panic to eat. Okay, so you don't eat. This is a post-cholecystectomy syndrome with a gallbladder in situ. Because if it takes a little bit of the gallbladder, admitting this is not a duplication. So I think this is not a very difficult operation to take this gallbladder. It's very different to treat biliopathy. Portal biliopathy is a very, very difficult disease. There's mature as experience. This is nothing to do. This is just how many of us do a cholecystectomy and when you open, we found liver cirrhosis. It happens, you know. It happens now less and less, but it happens, and we take the gallbladder anyway. So I think it's not to take this gallbladder even with a portal with this cavernoma. This is not a very difficult operation. It's a very careful operation, of course. Okay, but
I have to say two words. One, I agree with you, Eduardo. The extrahepatic complication of the portal. I think it could be at birth. For, you know, on all the patient with this, other patient with this condition that I have to treat, it was only for bleeding. That means the extrahepatic obstruction of the portal vein only by bleeding. That means if there is no bleeding, it is no symptom. And you have patients with this disease who spend all the life without any symptom. And in these patients, you said there is no varices. That means that it could be that she has this portal obstruction since birth. You have to ask her if she has infection of umbilical vein or she received infusion. You know, at the time it was made.
No, she did not. I asked about that.
You asked. She don't have. Okay.
I asked about that. She did not. No.
She did not. Now, I disagree with you, Eduardo, about the remnant gallbladder. The cause of remnant gallbladder is that the surgeon discovered the huge portal pedicle. The portal pedicle is huge. Sometimes you don't see the varices. You see it is a huge he cannot palpate by laparoscopy. And then he see very large, and he remain very far, the portal pedicle. This is why this is remnant. Now, the symptom of the remnant, I doubt. And last word, Eduardo, you say post-cholecystectomy syndrome. I am not sure. Post-cholecystectomy syndrome is when the symptom before the cholecystectomy exists. And this is a new symptomatology.
Henri,
This is not the. At that time, I prefer to speak about complication of cholecystectomy, not post-cholecystectomy syndrome.
Okay, but this is
But
just
I don't know the
sex
complication.
Okay, I present 15 years ago or more even in Paul Bruce a case of a nurse. She had done 17 ARCPs in 1 year. You remember that case? 17 ARCPs in 1 year, and the other horrible pain after a cholecystectomy. And Gilles Mentin, and I think Lawrence also was there, and we decided in this Compagnons meeting, they decided I operate the patient. I took out this cystic dilatation, and I did an operation. I did a biliary enteric operation, and the patient is completely free of symptoms after that. So, and the symptoms are very similar to that. Was a remnant cystic duct dilated with a lot of sludge, and she had 17 ARCPs in 1 year, and to treat this Botox. I think this is a little bit ridiculous, but okay. I think this is very similar to that, and I was told to take out the cystic, but to do a biliary enteric operation. That's the only difference from that case. I think that patient, if you do an operation, if you take the gallbladder with very careful, then I think that patient it will be treated. Okay, that's all.
Why don't we let others who are not on the screen right now to make some comments, because we monopolized the discussion, and let's just see. Does anybody else want to? Hi.
Yes. Hey, Manuel here. So I was hearing this. I think seriously, this lady had a severe acute cholecystitis. She was performed a cholecystectomy. It seems like whoever did it had a difficult time, ended up in a partial cholecystectomy. Maybe due to the inflammation at the time, she had acute portal thrombosis, which chronified after this period of time. It's basically this. And the weight loss, well, it can be, if you don't have any tumor markers that are rising, you can't really go on to cancer just because of weight loss. It can be due to pain. But this is basically what I think.
Who is speaking? Who is speaking? Can you announce
Manuel Jacklich was that. Sorry, Professor.
Who?
Manuel.
Dimitri?
It's Jacklich.
It's Manuel Jacklich. That's what I would. Anybody else? I see Tom Aloya. I see Timothy Pollock here. I see Jean Robert. Maybe you have a comment. Anybody?
I have no comment. It's a very interesting discussion. I am fascinated by the weight loss. The patient doesn't disappear. I am surprised because 59 kilograms, it's incredible. She was really obese, I think, before.
Yeah.
But I have no comment. I think it's a very difficult situation. Very difficult situation. I try to be non-invasive, but perhaps Laurence was right when she said pancreatitis may be the cause of the pain, because it's an incredible pain. To lose 59 kilograms in 1 year, it's incredible for me. Incredible. So I'm sorry, I have no solution. Magic solution.
Okay.
No magic solution.
We need to. we need to conclude for we have 1 hour and a half discussion of one case, and we have no. If you think it is the remnant, find a way with your radiologist or laparoscopist to drain without surgery this remnant gallbladder. Right. This was the suggestion of Florence. I agree, but find a way. I am sure you have brilliant radiologists. They will find a way to do that or laparoscopic. We need to go to the next case.
It's more dangerous than cholecystectomy.
No.
Is more dangerous than cholecystectomy.
No.
Okay. You decide.
Okay.
Dimitri decide, and then
I'll let you know.
Next month we will have the answer what happened to this patient.
I will report.
Now we have another case.
I will report.
Okay.
But thank you.
We
for
go
all
to the next
comments.
case.
It's very interesting.
The next case. Who is speaking now? The next case there is Rashad. Rashad is here. Rashad is here.
Sorry, Professor Prashad said
yes, Rashad is here. Can you put Rashad on the screen? Yeah, Emmanuel Jacques and Rashad, the two next speakers.
Rashad a while ago commented he had to go to OR. I don't know if he's still in the reunion.
Okay, at that time we ask Manuel Jacques.
Okay, we'll start.
Manuel?
Will do.
Manuel is here?
Yes, I'm here, sir.
Il est là.
Rashad.
Okay.
Rashad, you listen to us. Rashad, you need to speak. Your slides are blocked. Rashad, your slides are blocked. They are not advancing. Where are you? In some pyramid?
He is not on the chat. Oh, he's there.
The microphone.
Yeah.
Rashad, microphone.
When we were waiting for Rashad, just invitation for the guys to push in the YouTube channel to inscribe him, who is not inscribed yet.
Yeah. Rashad needs to stop sharing his screen, right? If we're going to move to another case.
I'm not sure he's listening.
Yeah, his microphone is not on. I don't. Marcelo, can Danielle unmute Rashad?
Yeah. No, we can't do that.
I see.
It's necessary for him to turn on his microphone.
I sent him a message.
We can remove him now and then begin to for another case.
Re-enter.
What do you think? You can do that?
Yes.
Send him a
Yes,
message
We
on
have one
WhatsApp.
case too.
Another case. You go. You have a case, I think. But Manuel.
Yes, we have one too.
Valerio is waiting for a case.
Valerio is here. Okay.
Yes,
Are you
I have
ready,
a case to
Valerio?
present if needed.
Good, good. Go on. Go on. Yes, good.
Valerio, okay, go on.
But Rashad, you stay with us. Don't leave.
Okay, you see my screen?
Yes.
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 Yes, yes.
Yes, yes.
Yes, yes, Valerio. Go ahead.
Okay, so it's a short case, a patient that I saw 10 days ago for the first time. So a 57-year-old woman with a quite low BMI, excellent general status. She had no major complaints except some slight epigastralgia, no pain, no itching, normal stools. And she did in March a general workup because she changed her general practitioner. Who did a blood sample, and gamma GTs and alkaline phosphatase were slightly elevated at 110, for which she did an abdominal ultrasound showing a huge right liver mass, and an abdominal CT scan showed this huge mass that you see here in the picture, 16 centimeters wide. Here in the arterial phase, there was a slight peripheral arterial phase enhancement, and on the portal phase, this kind of central necrosis, which was described by the radiologist as central scar. And so, sorry. So she was told to be a benign lesion, and because of coronavirus, everything was postponed of around 3 months. And I saw the patient 2 days ago. I did an anamnesis and find out that in 2003 she had the resection of right parietal meningeal hemangiopericitoma. No neurological sequela. She's totally asymptomatic, just a little right upper quadrant heaviness. And so I launched a workup, which is partially still ongoing. The MRI of the liver shows this kind of mass, which is centrally hyperintensive in T2, with arterial hypervascularization, kind of portal and venous phase washout, and very in diffusion weighted MRI, it was very intense diffusion. So central necrosis, a couple of biliary cysts, nothing else. So on biology, strictly normal biology with gamma GT and alkaline phosphatase, which were slightly elevated. All the rest was normal. Viral serology was normal. Alpha-fetoprotein 899 also normal. And on chest CT scan, we see 7 bilateral nodules. I pointed out the largest ones, which measure between 10 and 14 millimeters. And there are 3 other nodules which are measured around 2-3 millimeters, so very tiny, small. Lung, probably metastasis, which have same characteristics than an hemangiopericitoma on the MRI. So this is the case presentation. So the question I want to raise, do you think we need biopsy to take decision on kind of to propose to the patient, to have a histological confirmation, yes or no, and to see eventually the mitotic activity of the tumor. Do you think is it wise to propose to the patient a right hepatectomy and to go on the second phase on lung surgery for the resection of the 7 metastases, which are technically resectable except one? And what is the place of chemotherapy? Those are the questions for questions.
Okay, you finish? Okay, Valerio, thank you. It's a very interesting case. Can you put the X-ray? You let the X-ray. I think really that the first step is to have the confirmation of the histology. I think for me, we need to have histology, and the best way is the double needle. The double needle showing the tumor with a large margin of normal liver to protect and to put glue and to have in one day we have the confirmation of diagnosis. It is an emergency in this case.
Right. And do you think really that histology is needed as the imaging is very characteristic?
No. C'est pas caractéristique.
You know,
for the radiologist,
we need to have one of the.
The radiologists, which are quite experienced, say it's a very characteristic feature of hemangiopericytoma.
Pas 100%.
But Valerio, this patient has no risk factors, right? I mean, what is the justification?
No, she has been operated 17 years ago of resection of meningeal hemangiopericytoma.
Okay.
And, but in the last years, she had no follow-up. And so she comes now.
I think Valerio, for example, if you see.
And
Valerio?
Yes.
Just two things. I mean, I think we need to be very simple, and it's so quick to do. You may have lesions in the lung and lesions in the liver. I need to do biopsy. I'm not 100% sure it's all cancer. It's easy to do. You save time and you have the final answer. For one reason, because the size of the tumor, of the lesion in the liver, I'm not 100% sure it's a cancer. If it's a benign, then you have your answer. You may have both pathology, okay? You may have lung metastasis, but not necessarily a liver metastasis. And I'm surprised because she did not lose weight. She's still in good health, as you said. This is an incidental finding. This is a pure incidental finding via an ultrasound. She has no symptoms. So biopsy, and I have my answer. And following this, then you know what to do.
And your biopsy can direct your potential chemotherapy, no? That you prefer to be done neoadjuvantly.
Yes, Laurence?
Yeah, I do not agree with the biopsy. In fact, personally, I would operate this patient and remove this huge tumor, which is probably a meningeal, like you said.
Yes. Yes, Laurence.
Your microphone.
My attitude of proposal was this: to go directly on surgery. Of course, if there are not, she will do this week again a brain MRI and a PET scan. Of course, if there are bone metastases or if there is one, but I think as the liver tumor is quite, in brackets, easily resectable by a normal right hepatectomy, and lung metastases are also quite easily resectable. Surgery, chemotherapy, in my as I saw in literature and I asked to the brain tumor board, is not is only the last option.
I agree with you. I remove the tumor and then I focus on the pulmonary metastasis, and I do biopsy of those nodules in the lung. But for me, the easiest is to operate this patient because the mass is huge. There is no chemotherapy active on that, and then I would focus on the rest of the disease. But I agree with you. After, of course, what you planned, which is a PET scan and brain imaging. So
Yes.
I would
Yeah,
operate.
I agree. I wouldn't do a biopsy either. You know, I think I would do a PET scan and before the surgery, and then I would proceed with the operation. And that would be your ultimate biopsy. I think that.
Well, I think the only information that the biopsy could bring is mitotic activity and the aggressiveness of the tumor eventually, which could change the attitude.
It's called the extensive surgical biopsy.
Yes.
Instead of enucleation, if it's a benign lesion. You see, that's my thinking behind it.
Gina, it's not a benign.
But then you can biopsy during surgery and make a decision.
If it's benign, it's an adenoma. If it's benign, so it has to be removed.
Yeah.
So anyway, it has to be removed.
We agree for the surgery. Do the liver resection, surely.
Yes.
I think.
Okay.
I am more happy with your aggressivity now to treat patients. I'm happy, you know. Okay, just a light hepatectomy is nothing, you know. I think I agree with you now. I agree with your aggressive approach for the patient.
Last time it happened like this. After 1 hour,
I didn't catch it. Sorry.
No. It is no more working. No more working. Marcelo, do you have explanation? We have very bad transmission for all the people.
We listen very well.
Listen
Yes, we do. Yes, we do. It's probably from your connection.
Yeah, we hear you really well. No problem here.
So I see in the chat, Oscar, you propose the eventuality of a fibrolamellar HCC, which is indeed a feature on the imaging. Also the alpha fetoprotein, okay, it's not very, it is normal, and she has no.
I propose a quick surgery after biopsy, but if you think need, you do the surgery. It is a young, it is possible to remove, and then we see what to do after the surgery. But I agree with Laurent, this is a big tumor, and the tumor will.
We lost the master.
Yes.
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 Hopefully for the short moment.
Oh my God. Oh my God. We lost the master.
What are we doing?
May I say a few words?
Yes,
may I say a few words?
Sure.
Valeria, the first diagnosis, I thought it was a fibrolamellar, even with a normal alpha fetoprotein, which is rather usual.
Yeah. Yes.
We have the history of the hemangiopericitoma, but I don't have such experience to say if it is really the feature of an hemangiopericitoma in the liver.
Right.
It's not very usual as other vascular tumors, as hemangiosarcomas, but anyway, I think I will agree with you not to biopsy and go further, very straightforward for surgery, because it's a huge mass that eventually she will have symptoms. So afterwards we have to treat liver lung metastasis. But I think that the first step is to remove this mass in the liver. So, Eduardo, I agree with you.
Yes,
I will
finally, it's a very good case.
You,
To finish, finally, we agree.
you're right. You're always right, Eduardo.
He doesn't finally agree to operate the patient. I'm very happy with her for lunch. Very happy lunch.
You know, Eduardo, all the other cases were not surgical. This is the first one you have to go.
Do you see the images?
Yes, we do.
Yes.
We do.
You see the images. There is also a splenic artery 2 centimeter aneurysm, which is of course also an incidental finding. Would you embolize it?
What's the size?
2 centimeter, 2.1, I think, just above 2 centimeters.
It's easily stentable also, in case.
Valerio, if you
But not
operate,
prior to the resection. I think I will leave it for the post-operative period.
Okay. Laurence?
you have to treat the aneurysm. It's important, particularly if you do the resection, because you will have a sort of portal hypertension after that. So you have to treat it. But personally, I had that. You can operate it. You can exclude it surgically during the hepatectomy. It's not a very important procedure.
Okay. So I have to admit that I sent her yesterday to the angiographist, and they embolized the because I'm in my notion more than 2 centimeters, the risk of rupture is important.
Yeah. Yes, it is.
Yeah.
And
yes,
if,
it is.
if she does a rupture after during surgery or after surgery, it would be a mess.
Right. That's fine.
That's it. Here it is. Cool. Okay.
I want to know the biopsy, so go for surgery and let us know what it is.
I'll tell you next month.
Yeah, I'm very curious to what it is.
Me too. Very curious.
I'll tell you.
Let's continue. Do you agree to continue with another case?
Yeah. Can you hear me now? At the moment, can you hear me now, or can you see me?
Oh yes, finally.
Yes, Rashad, we hear.
Yes, Rashad.
Yes.
Can you hear me and see me now?
Yes.
I'm sorry about what happened. I don't know what was what exactly went wrong, but I'll start my presentation. Okay. Yeah. Look. Okay now.
Yes.
Okay. Right. Hello from Cairo. We thank very much Professor Bismuth and all the organizing team. The case I'm presenting is from Ahmed Mahir Teaching Hospital, 700 bedded, and it's been going on with us for something like 2 years, over 2 years.
So I think everybody has to stop the mic, otherwise it will be a mess.
Okay.
Yes.
Yeah, he's a 24-year-old male patient who came as an emergency with exacerbation of his abdominal pain, mainly left iliac fossa, without any other symptoms, nothing relevant in the history, slightly tachycardic, but hemodynamically stable, tender on the left iliac fossa, but some voluntary guarding, but no signs of peritonitis, localized or generalized. The abdominal X-ray showed that he was quite constipated. He's had the pain for 3 months before, and it has some investigation. First of all is the coronal, which shows quite constipated, but no obstruction. And in the pelvis, you can see some mural thickening with shouldering that you can see it here, and about 5 centimeters, and a radio opaque shadow, which we didn't know what exactly it was. He also had a endoscopy, which stopped at 20 centimeters, and the biopsy was tubulovillous adenoma with highest grade dysplasia. And we started conservative treatment trying to empty his bowel. We didn't succeed, and we decided to proceed with laparotomy, which showed a big mass in the sigmoid, rectosigmoid colon, marked inflammatory reaction, adherent small bowel that we couldn't separate, and a small amount of preperitoneal fluid. we decided to go for a radical resection. There was retroperitoneal adhesions as well, and we obviously see a retroperitoneal perforation and pop out this foreign body, which is a stone of a fruit. So we did the resection and Hartmann procedure, terminal left iliac colostomy and oversewing the rectal stump and primary anastomosis of the small bowel. He recovered well, but the pathology came a bit of a surprise. It was an infiltrating low-grade adenocarcinoma with perforation gone through the wall with some perineural invasion. Lymph nodes 2 out of 24. The margin proximal distal clear, but the circumferential couldn't assess it. So in fact, he was a T4N1 MXRX. We staged him after that. The tumor marker were clear and the CT chest on the abdomen, and he went into chemotherapy. FOLFOX, reasonably well tolerated symptoms. He received 11 doses of the 12 planned, and when we review him 6-7 months later, the tumor marker were normal, and the colostomy endoscopy was clear, and the CT chest was clear, but the CT abdomen showed there was a focal lesion, no really appreciable enhancement in segment 7. He couldn't do an MRI, and we decided for a CT-guided biopsy, which was possibly technically difficult because it was reviewed 3 times and it was inconclusive. There was a lot of pressure to reverse him, especially when he was young, and we convinced him that we have to be sure what it is exactly and to review him and then repeat it again. And he came back June last year. Tumor marker were normal. The CT showed that there was another lesion, a new lesion with some peripheral enhancement. You could see it here in the sagittal section, and you can see it here, 2 focal lesions. So we decided to proceed to PET scan, and both of them show uptake, although it was not high. The SUV max was 3 and 4. And the other new things, there was a lesion in the linea alba with a high SUV max. And the lung, there was a small nodule in the upper pole with small SUV max. We're not sure about it, but we decided for a second-line chemotherapy, FOLFIRI, which he tolerated with reasonably well, but with a lot of symptoms. But the new thing was the deep-seated pelvic pain. Nothing obvious on examination. He had a CT. In the meantime, it didn't show anything. He had 5 out of 6 doses, and he came back again this year. We decided to proceed to PET scan again. This is straight the result of the PET scan, and in the orangey color was the previous one for comparison. The linea alba has progressed. There was a new one in the pelvis in the mesorectum. The segment 7 was stationary. The segment 8 was progressive. The new one in segment 6 near to the gallbladder. And the lung, the anterior upper lobe was still low in SUV max, but increased in size, and a small one in the subpleural one. Briefly, I'll show you the pictures. I don't have much time to show to run the film itself. That's the uptake of the anterior and the linea alba and the pelvis. This is the linea alba one with height uptake, the pelvis one and the uptake. And that was the uptake of the liver lesion. You can see it in the dome and near the gallbladder. Both of them showing peak. And the lung, the left-hand side one showed it increased in size, and the small subpleural one, which is given there. We did the RAS mutation on him, and the result was there was no RAS gene mutation, and the genotype was wild type K and RAS gene. We saw him 10 days ago. He was kept on Xeloda. There was a mass obviously palpable in the abdominal wall. The CEA has gone up. We repeat an ultrasound, and we show that the dome has gone bigger at 4 centimeters and the gallbladder from 1.6 to 3.2. This is the lesion, obviously disfigured scar, and the ultrasound on the right to show the liver mass. This is the biopsy we did a few days ago, and it confirmed that it was a positive for adenocarcinoma. So if I'm to summarize it for you, is a 24-year-old patient presented acutely with perforation of the rectosigmoid due to moderately differentiated adenocarcinoma. At that time was T4N1 MXRX. We did a heartland procedure. He received FOLFOX, but he showed evidence of metastasis that we confirmed he was now a stage 4B. He received a second course of chemotherapy of FOLFIRI. Despite that, he is a progressive metastatic disease in the liver, the linea alba and pelvis, and both of these two he's symptomatic of, and likely pulmonary. And he has no RAS gene mutation. He has a wild type KN and RAS gene. Presently, he's just on Xeloda and analgesia. And I wonder what you would suggest for his management.
Rashad, do you have the chance to do biologics on this patient? She has a RAS wild type tumor.
He has a wild type RAS one. That's the one we've done so far on him. Okay. So what was your question then?
I was wondering if.
Can I speak?
I was wondering if you
Yes.
can do to add the cetuximab or panitumumab to this patient, because she's not responding to any chemo and she's on Xeloda, which is going to have the same results.
Yeah.
Yes, I agree with you. She is progressive on this chemotherapy. She has now not a real very intensive chemotherapy. I think we have to upgrade the chemotherapy with targeted therapy or anti-angiogenetic, but it's very important to control the disease by chemotherapy before going to aggressive surgery.
May I do a comment?
Great.
Just a little comment.
Yes.
A few comments. Perhaps, due to the situation, I completely agree with Hugo and Laurence. The risk of a carcinomatosis is very high. Perhaps the mass on the linea alba is only the emergence of the carcinomatosis in the peritoneum. Remember that initially there was a posterior perforation of the sigmoid. It was T4 with a perforation, and now in such an evolution, perhaps she has also a carcinomatosis. So the urgency is to update the chemo, I think.
Do you reckon the continuing chemo and adding the targeted therapy, the anti-angiogenesis and the anti-EGFR, or just the targeted therapy only?
Yes. The targeted therapy only won't be effective if you don't add classic cytostatic regimen. I think you have to do both.
Upgrade the protocol.
Yeah.
Rashad,
it's a terrible story.
Yes.
It's a terrible story
Rashad,
because the chance of response is about 20%. So it's terrible because the risk is to go to palliative care because the chance of response after 2 lines and then the new drugs, despite the new drugs, the chance of response is about 20%, no more.
You reckon
Rashad, I think we need to conclude. Unfortunately, today there is no surgery, sure, to find the best palliative treatment is almost like a general disease, and is very young, but what to do? You have to find a solution by improving the chemotherapy. Okay? And
yes,
we have a last case.
Would we consider chemoembolization or radiology or radiofrequency until then?
No.
Not for the time being.
No.
just the targeted therapy,
No,
the
no.
systemic therapy, and review the result. And hopefully, obviously, we know that he is young and perforated, and the chances, at least, it's going to be a palliative treatment. But thank you very much. Thank you very much. It's been positive.
Thank you, Rashad.
Thank you.
Thank you.
Thank you very much.
Now we have a last case by Manuel Jaclis. Manuel Jaclis is here.
It's Professor. It was Jaclich and us. Jaclich had to leave for the OR, but we also have one case to present.
Okay. Shortly, for we say we stop around the 2-hour meeting. Okay, go on. We go on.
Yeah. Okay, so this is a quick case. This is an actual case of a patient that we did we saw about 10 days ago, and we have in the wards waiting for a solution. Sylvia is here to present the case for us. I think she can share the screen. Sylvia?
Hugo, you have always a nice lady to present, huh?
Yes.
Always.
Le les hommes.
Sylvia, can you present, please? We need.
Don't forget me.
Yes. So we need your help with this case.
Okay. Just a moment. Good afternoon. So we are here today to present you this case of a young female patient with only 35 years old, with no medical history, that 1 month ago starts with jaundice, with cholera and pruritus. She was admitted initially at another hospital, and they performed an abdominal ultrasound that shows an intrahepatic bile duct dilatation due to an expansive perihilar lesion. At this time, in terms of lab work, she had an obstructive jaundice with a total bilirubin of 7.7. They performed a CT scan that we can see here. The CT scan showed the lesion centered to the hilum with a marked stenosis of the confluence and the right and left bile duct. And as we can see in this phase, this mass is clearly infiltrative and extends into the intrapancreatic bile duct. So at this point, we have what it seems to be a type 4 Klatskin tumor with extension to pancreatic bile duct, to intrapancreatic bile duct. As we see, they performed a transendoscopic ultrasound that shows the known hilar mass and performance cytology. And after that, an ERCP and placed 2 stents. The patient was sent to us to refer to our center at this point. And you can see here that bilirubin levels went down, and we have and she had a CA99 expressively high, and a IgG4 high too. We repeat the analysis of the pathology, and as we can see, it seems to be a random proliferation. Cells look atypical and sometimes with gland formation, and a disorganized proliferation with atypia, and extensively AE1, AE3 positivity, compatible with cholangiocarcinoma. We repeat the CT scan at this point to plan our approach, and this is the most recent CT scan of this patient, already with 2 stents. And the hilar mass, a later phase, so you can see better. So we want your opinion, what you think we should do to this patient.
Let me just add something. What we saw in our discussion, we saw, first of all, we saw that the patient, the tumor is moving along the bile duct until it reaches the head of the pancreas. The first portion, the intrapancreatic portion of the bile duct, has a tumor. It stops a little bit after that, but it invades partially the pancreas. Also, we saw that in the portal confluence, there is a slight, let's say, a small invasion of the partial confluence, thinking that if we could resect this, we would have to at least do a small resection of the portal vein. Also, the artery seems free.
It seems free.
For the left side.
So the question, Hugo, is do we perform this patient, which is young, duodenopancreatectomy and extended right liver resection?
Yeah. At the same time,
portal vein resection.
Yes, and we
yes,
block section of both. Of course, we need to do the treatment of Florence for the hypertrophy of the left lobe.
Yes.
Laurent, you are the hero.
The rasp.
Sorry.
The rasp.
Don't you think that chemotherapy in this case is some neoadjuvant treatment before surgery or not?
Well, Oscar, I think the rate of response for this type of tumor is below 30%.
Right, it's not good.
I think she's 35 years old. We're going to lose the chance.
Yes, but it's a quite advanced cancer. I think that you can exclude patients that should not be beneficiated by surgery, I think. If the patient is stable or has some response, you can go further for surgery and thinking that she would be beneficiated by surgery. But anyway, at least in my experience, the few cases I operated on like this, they progress rapidly after surgery.
Sorry, Sylvia,
I agree. I don't think she's going to do well.
Just, sorry.
Where was the positive, the adenocarcinoma? It was at the ERCP? Where did you have the adenocarcinoma sample?
Endoscopic ultrasound.
At the biopsy.
Okay. And the
lymph nodes were
positive or negative?
Excuse me?
The lymph nodes. Did you sample the lymph nodes, the celiac,
no
lymph node?
No positive. No suspected lymph nodes.
Okay.
Hugo, why you don't try the protocol of the Mayo Clinic before the surgery? Because she is very young. This is very extended disease. The risk is quite high because you have to do hepatectomy plus duodenopancreatectomy. Perhaps it's reasonable to try neoadjuvant strategy in such a young patient with an extended disease. Because the results
with the Mayo protocol.
With the Mayo protocol, because even in Japan, the results are not very extraordinaire, hein? Very formidable.
Jean-Robert, It's,
I agree.
Absolutely. The biliary cancer is very extended because it comes from the confluence, if I saw it, and all the biliary tract. So for Mayo Clinic, it's a huge radiotherapy perspective, you know. Mayo Clinic is good for really hilar tumor, small hilar tumor. Here, the tumor is very extended. I think she has dysplasia all along. So my question, I saw Sylvia the second CT scan, and I'm worrying about the infiltration in the liver, even in the left liver. I don't know if it's because of the drains or not, but the main point is, will you have a left biliary duct good or not? I'm not sure it will be a safe margin. I'm afraid that she has all the biliary tract invaded by the cancer.
I think if you see the histology, it has a marked inflammatory reaction, desmoplastic reaction.
Yes, I
but
hope
on the
it's
first
inflammatory.
CT scan, the violet seems
and
pretty...
Sylvia, I'm quite astonished on the images on the gallbladder, which is very thick and very homogeneous, which let's think me to the xanthogranulomatosis polycystitis that we see sometimes. And are you sure on the histology? Because there might be some mistakes on histology examination. It might be, we saw a case a couple of years ago of xanthogranulomatosis polycystitis, which was quite the same picture than you have here. Of course, the histology with adenocarcinoma is quite worrisome.
Yes, we have that question at the point that we discussed this question, the first discussion. So we ask for the samples and we analyze at our center again, and the result was the same. And we have immunohistochemic that is very clear that it's compatible with a cholangiocarcinoma.
Just one question, Hugo. Did she respond well when you put your stent? Did the bilirubin came down and everything
came down? 7.7 was the maximum. And after the stent, she's now with 1.
Because I agree with...
Sylvia.
Just to add something, attends Laurence, une petite seconde. Just one thing, it's because you have, very often with this patient, you have a very, very, very small window where you can act. After that, it's too late. So if you say, that's why I asked, because now she responded well to the drainage, you're away from infection, because the risk with them is to go to cholangitis and cholangitis. So it is true that you have to act very quickly. And yes, why not go, because she's young, to that. I agree that there is a risk that the margin on the left duct, it's not easy, but we are hoping it's inflammatory. But if you have to operate, you have a very short window in time, very short.
Nobody wants to comment the EGFR of that patient. Nobody has any importance for this EG4 elevated in that patient.
No, because it can be related to the inflammation. It's only 300. It's the upper limit. It's not hugely elevated.
I disagree. I think this patient has a very bad biology. I think if the patient is not going to respond to neoadjuvant chemotherapy, this case is going to progress very, very quickly. And I think your neoadjuvant chemotherapy is actually a test to see if there is any chance of response, because we all know that these cancers, it's a surgical disease, but without chemotherapy, they all recur virtually 100%. So I personally would do neoadjuvant chemotherapy, and if there is a response and stabilization of the disease, then I would proceed with resection. But otherwise, I think it's a bad biology, and she's going to recur very quickly. That's what I would do.
Dimitri, you're right. It's a very bad biological. But how would you assess the response in that case? It's very difficult because you have not.
I would assess the response.
You know.
I would assess the response the way it actually is defined by NCCN guidelines. It's the lack of progression. If in 3 months after neoadjuvant chemotherapy there is no progression, then you have a response.
But they die with infection, these patients. They die with cholangitis. This is the risk. So you have to be very careful.
So you're gonna put her through a major operation with a long time of recovery, no matter what anyone says, and it's going to take her a month, maybe 6 weeks to recover. And that's assuming that we have no complications of surgery. And in 3 months, which is a month and a half after her recovery of surgery, she might have multiple metastases throughout the liver. And basically, you just took 3 months away from someone's quality of life. I'm sorry, I disagree.
We agree, but it's a catch-22, and we all know that these are the difficult, very challenging cases, and I agree. But the problem is that I agree with Laurence, and I agree with you, it's a bad prognosis. But with Laurence, this neoadjuvant chemotherapy, you cannot assess the response. It's not true, because sometimes you have infection and they die from infection, and you are in catch-22 anyway. So
I think lack of progression is your response.
It doesn't appear.
Well, lack of progression is not necessarily a response, but it's evidence that there is no progression.
The patient is drained. And today, there is no infection. Yeah. You can try to do a neoadjuvant strategy because the surgery was a very important surgery, very extensive, without pancreatic reconstruction, like recommended by Cocudo. You have to put the pancreas outside.
Outside, yeah.
And to do the post-operative chemotherapy is very, very difficult. Probably 6 to 8 weeks to wait before any treatment. So it's better to treat before and have an idea of the natural history of the disease, because it's a very extensive disease.
I agree with Jean-Robert 100%.
I think that, no, it's only my opinion. Huh? It's very difficult.
I agree with you, Jean-Robert. This is what I would do.
You are probably right. I have a question about the strategy for all I agree with the neoadjuvant therapy, because it's a bad tumor. But I have a question because in that situation, in my experience, we are not doing a drainage of both livers. In fact, we are only we drain only the left liver, and we do the portal embolization of the right liver with no drainage, liver drainage, and this enhance the hypertrophy of the left lobe, because only the left lobe is drained. So the right lobe, with the obstruction of the bile and the portal embolization, has a better atrophy, and it's more rapid. So do you always drain the two livers even if you plan right hepatectomy?
No.
Because
Usually not.
Two possibilities
Only if needed.
of infections.
But it is a stage 4, right? Stage 4.
Yeah, stage 4.
It is.
Laurence, I asked you the question about the RAS. What is in this case, do you think with the portal embolization indication of the evangelization, as you described?
We think this is a good indication, because the remnant liver, you will just leave the left lobe. So you need a massive hypertrophy of the left lobe, particularly in that case. So I think I would do a double embolization, even the middle hepatic vein. So the right hepatic vein, the middle hepatic vein, and the portal vein. And this can help for the very little left lobe to hypertrophy well. So as Jean-Robert said, it will be a very, very heavy procedure for her, the drainage, the portal embolization, and after the surgery with the pancreaticobiliary. So we have to prepare it. But I am concerned about what said Gina, because in my experience, those patients, even drained, has endocarditis.
Yeah.
And very frequently they come back with sepsis. And if you, well, I think it's very difficult. So,
Very difficult, yeah.
well, it's really a heavy procedure.
Okay. Now, if I summarize, I have the feeling.
I don't agree with Gina. This EG4 is not a small EG4 elevation. And this kind of patient is a very young patient. And this could be a tumor, of course, a cholangiocarcinoma, but inside of autoimmune disease of that lady. And this could be the difference between the prognosis of that patient. So I would think that this elevation of the G4 is not at all typical of just a kind of tumor. This is 304, the maximum is 200, and there are 4 kinds of EG4, and this EG4 must be studied, and could be changing the prognosis of that lady. And I think it deserves a very aggressive approach, surgical approach, a very aggressive surgical approach. And I'm sure that Sugu is going to do this right appendectomy extended, of course, careful with the hepatic liver failure after operation. But I think that joined also the corticoids of that patient could be an impact on the neoadjuvant therapy.
Okay, but, Eduardo, what to do? I summarize. I have the feeling, I try to summarize, the feeling that the recommendation, and you say, Hugo, if you agree for that, the recommendation is to do blood embolization of the vein and the portal. Of course, the left lobe is drained, but the right lobe is excluded. That means the risk of cholangitis exists on the right lobe. And the question is about the neoadjuvant chemotherapy. What after listen all of what is your feeling now? What do you propose to your patient? I say that for at the end, it is the surgeon in charge who decides. So you listen all, and then what is your decision? What do you think? You go.
Who is going to operate that?
I think. Well, I think our inclination is to go for surgery, because I really don't believe that testing this patient with chemotherapy is going to give her a chance. Although I think that the tumor has a very bad biology. I would be inclined to do B embolization and to go to surgery and go to chemotherapy after that.
What would you do
Although
between...
I think it's a very bad case.
Yeah. What would you do?
It's a very bad case.
What would you do during these 4 weeks?
Yes.
After,
last comment.
After the double embolization, what would you do? Because I agree with Laurence for one thing. Are you going to remove the stent on the remnant liver?
No, no, it's too late.
Or not?
Well, if she's, I would do no manipulation at all.
That's my question. I don't know. I don't have the answer, but I'm interested to know. Would you keep it?
Yes.
Yes.
On the left side.
Yes.
Okay.
Yes.
Another thing, yeah, and a quick question, because I think there's another doubt we have. Assuming that we go to surgery now, we have the option of doing the right extended with portal vein and pancreaticobiliary, but we can do this in 2 stages.
Separated.
Because this is reported to have a mortality of 10%.
Yeah.
So, in the technical point of view, should we do both the Whipple and the hepatectomy at the same time?
Oh, yes. You're obliged.
We go just a comment. if you do in the same time, I have a small experience because these patients are not so frequent. But the last I do, it's better to don't reconstruct the pancreas because the risk is the pancreaticoanastomosis, the pancreatico-jejunal anastomosis. You have a small pancreas, a small duct, very. It's very risky to do the pancreatic operation.
The 10%.
So I try to delay the reconstruction.
The 10% mortality is a number you had before all the preparations. I mean, if you have a good embolization, the right hepatectomy will not be such a heavy procedure in all the procedure. The most important is the pancreaticodenectomy, and I agree with Jean-Robert. If the pancreas is not really good, and it will not be, just don't do the anastomosis. And so I'm sure at this age you do not have 10% mortality.
Yes,
I was basing myself on the last meta-analysis published on HPV in 2016 that was considering around 10%. I think it will be less, of course.
Hugo, I think if you split the operations, it's not oncologically safe because you are splitting the two operations within the tumor because there is an infiltration that goes through the pancreatic bile duct. So I think it should not be recommendable to do in two steps. At least, perhaps Jean-Robert has a great experience, and you can not reconstruct the pancreas, but the resection should be in one piece, I think.
Yes.
I will cover this patient with antibiotics in the interim. Do not stop the antibiotics, even if it's not asymptomatic. Okay, that's what I would do.
Okay.
That's the experience of infection. Yeah.
Okay, it's for Hugo. In order to close, do you agree with that? And at that time, do the surgery in this patient and let us know session. I think it's time to close. And I think it's a good session. I think there is technical problem. And Marcelo and Daniel perhaps may work to improve it. And why do you agree to have a next meeting? The official name is staff meeting of Compagnons in 1 month. At that time, it will be. Of course, some of us will be absent, but today there was, I think, around 30 people, 16 on the screen and 15 waiting outside, and sometimes some of them enter. I think the audience, the question is good. I don't know how many people were on YouTube. Marcelo, do you know that? How many people listening to us on YouTube?
Yes, 40.
40. How many people?
40 people now.
40 people now. On YouTube?
Yes, on YouTube.
On YouTube. And 16 and the screen.
Excuse me?
16 is the maximum. It's a pity. For we have a lot outside. It is not possible to be more than 16.
I think, Mr. Bismuth, I think we must define for instance, in every 4th week of the month, we will have something. This way, we will have, the people will look for us. It's very strange to have every week the discussion and divulgation to everybody. I think we should have one strategy to have the meeting in the 4th week of the month, for instance.
Yes, this is my idea. That means to have one week at the end of next month, and no more between. Possible now. Let me see. At that time, it will be the 29th of August, our next meeting at 2:00 p.m.
Okay.
So do you agree?
Yes, for sure.
Yes.
Okay. At that time, we may decide new case to have the answer for the case presented today, which was very nice, a very nice discussion. And to meet in 4 weeks with also a very fascinating case. Okay. Thank you, all of you. Thank you.
Okay.
Bye bye.
Bye-bye.
Goodbye.
Bye.
Thank you.
Au revoir.
Okay,
Bye-bye,
bye-bye,
everybody.
everyone.
Take care.
Parabéns, Marcelo.
Thank you.
Bye-bye,
Thank
everyone.
you very much.
Nice holiday, everybody. Thank you for your help.
Bye.
Nice job, Marcelo.
Hello, everybody.
Thank you.
Thank you, Danielle. Thank you, Marcelo.
Au revoir à tous.
Thank you, everyone.
Bye. Okay, bye.